Hello, everyone. Welcome to the second day of this incredible meeting. Once again, I'm honored to talk to you today about the focused ultrasound mediated blood-brain barrier opening in Alzheimer's disease. My name is Umer Najib. I'm an associate professor of neurology at the Rockefeller Neuroscience Institute at West Virginia University. My training includes neuromodulation and headache and facial pain, and I serve as the director of the WVU Headache Center and also the transcranial magnetic stimulation program at RNI. And I'm also on the team that is currently doing all the focused ultrasound clinical trials in Alzheimer's patients. I'm going to talk about on- and off-label applications of devices, and these are some of my disclosures. I serve as the principal investigator on clinical trials sponsored by Teva, Lilly, Electrocore, and Therapeutics, and I also serve as a consultant for Allergan and AbbVie. So for those of you who are not familiar with the physics behind ultrasound transmission, ultrasounds are mechanical waves with a frequency of more than 20 kilohertz. They travel with alternating compression and rarefaction, and thereby they transmit energy by molecular movements. The frequencies that are used for transcranial ultrasounds or transcranial focused ultrasounds are either what we call mid-frequency, around 650 kilohertz, or low frequency, 220 kilohertz. The speed of ultrasound transmission is medium dependent. For instance, water and soft tissue are excellent conductors, but air and bone are not. The transmission also requires a coupling medium between the transducer and the biological tissue, and typically degassed water is used for that. And in addition to this, there's a significant absorption and reflection of ultrasound while traveling through the tissues with different ultrasonic densities, so to say. For instance, the different layers of the skull, the inner table, the marrow, the outer table, and the extent of ultrasound reflection also depends on the incident angle. Now, the consequences or the biological consequences at the target, those depend on the intensity of the focused ultrasound, the frequency, and the duration of exposure. At high intensity, focused ultrasound creates tissue ablation. The mechanism is dependent on frequency. For instance, the mid-frequency systems, which are typically the 650 kilohertz systems, they primarily produce it via thermal ablation, whereas the low frequency systems achieve ablation via cavitation. At low intensity, under certain circumstances, focused ultrasound can also be used for reversible opening of the blood-brain barrier without causing ablation. For the thermal ablation, the typical usages, as you can see on the slide, are in essential tremor, Parkinson's patients, and then there's certain other areas under investigation for the low intensity focused ultrasound mediated blood-brain barrier opening. The applications include chemotherapy delivery around brain tumors, and that it is currently being investigated in Alzheimer's disease and certain other neurodegenerative disorders. Now, the low frequency, low intensity focused ultrasound can also be used in more of a neuromodulation role, without causing ablation, and also without disrupting the blood-brain barrier. And in this role, it's currently being investigated in disorders of consciousness, such as comatose patients, and then more recently in addiction. The MR-guided high-intensity focused ultrasound, or HIFU, is FDA approved for the treatment of tremors in patients with essential tremor and Parkinson's. This is done after a stereotactic frame placement and then MR-guided focused ultrasound delivery. There's no incision or skull opening, and typically this is achieved in 2 to 3 hours of outpatient stay. There's focal delivery of ultrasound energy with real-time live feedback, which consists of MR thermometry, direct lesion evaluation on the MRI images, and of course, clinical assessments. Over here, we use a 650 kilohertz high intensity mid-frequency system using high intensity focused ultrasound that generates heat focally and then ablates the target tissue. And overall, there have been thousands of patients that have been treated now in randomized controlled trials, and the safety and efficacy have been well established for this technique. Over here, I'm going to share a quick video of a patient before and after the procedure. As you can see, this produces impressive results. Now, low intensity focused ultrasound, on the other hand, can be used to open blood-brain barrier, and of course, the implications include targeted drug delivery. Currently, it's being studied in patients with glioblastoma for the delivery of chemotherapy, and in patients with Alzheimer's disease to see if there's a change in the amyloid load, and of course the future direction likely is going to be targeted drug delivery. Now, the blood-brain barrier, as you would know, is a diffuse barrier, mainly formed by the tight junctions between the endothelial cells, and this limits access of most substances from blood to brain. And typically, substances larger than 400 daltons are limited in their ability to cross the blood-brain barrier. Here you see a diagram showing different molecular weights, and as you can see, the blood-brain barrier poses a challenge to several potential therapies because of their larger weight and or mass, so to say. So the low intensity or non-lesional focused ultrasound, this is combined with microbubbles, and microbubbles, they consist of gas that is surrounded by a lipid or lipopolymer or polymer shell. They range anywhere from typically 1 to 5 micrometers in size. the microbubble shells are metabolized in the liver, and then the gas is exhaled. The microbubbles, they work by resonating in an ultrasound beam, rapidly contracting and expanding in response to the pressure changes of the sound waves. And it is these oscillations of the bubble that temporarily disrupt the blood-brain barrier and increase the permeability of substances to the brain. Now, this can be achieved in a very focal, reversible, and on-demand manner. Over the past 10 years or so, there have been several preclinical studies showing that safe and reversible BBB opening can be achieved using low-intensity focused ultrasound. And then more recently, there have been several preclinical studies showing that using the same technique of low-intensity focused ultrasound BBB opening in animal models of Alzheimer's, there's been plaque reduction, amyloid plaque reduction, and improved behavior. According to the World Health Organization, more than 55 million people have dementia worldwide, and as you would all know, these numbers are expected to exponentially grow and increase to about 140 million or up to 140 million by 2050. In the United States, 1 in 3 seniors die because of dementia, and despite more than 1,000 clinical trials, there's really no effective treatment or cure for this. Now, the very initial experiences of low intensity focused ultrasound mediated blood-brain barrier opening was shown in from Sunnybrook, Toronto. This was published in 2018. A series of 5 patients where safe and reversible BBB opening was achieved in the white matter of the frontal lobes. At WVU, at the West Virginia University, we did the first 3 cases in the US, and then were subsequently joined by our colleagues at Cornell. And last year, we published our initial experiences, our initial experience of 6 patients, where we were able to perform safe and reversible BBB opening in hippocampus and intrarenal cortex. This was the BBB opening was shown by parenchymal contrast enhancement. The figure on in the bottom right, you can see that at baseline, there's no contrast enhancement. Immediately post sonication, there's contrast enhancement. And then that resolves at around 24 hours post sonications. In some patients, it takes up to 72 hours, but in most patients, it resolves over 24 to 48 hours. Now, these initial experiences led to the development of a phase 2 safety and efficacy clinical trial. This is which is currently undergoing. This is an open label study to assess the safety of focused ultrasound treatment to open the blood-brain barrier in Alzheimer's disease across both superficial and deep regions of the brain. The safety aspects are assessed by clinical and imaging adverse events. And of course, the blood-brain barrier opening and closure is evaluated by contrast enhancement on MRI. The clinical endpoints are assessed by MMSE and ADAS, a cognitive subscale. And we're also looking at the effect on amyloid burden by evaluating beta amyloid via 18 F PET scans at baseline, and then 1 week after the last treatment, which is around a 60-day time point. This clinical trial is sponsored by Inside Tech with the goal to enroll 20 subjects. And as I mentioned, the intervention is focused ultrasound mediated BBB opening in hippocampus, entorhinal cortex, frontal, and parietal lobes, and looking at beta amyloid plaque burden. The eligible patients for this trial are patients with mild Alzheimer's disease between the ages of 50 and 85 years, with an MMSE of between 18 and 26, and who have positive beta amyloid on amyloid PET scan in the hippocampus, frontal, and parietal lobes. The major exclusions are listed on the slide, and they include ApoE4 homozygosity, which can increase the incidence of bleeding. Here is the basic overview of a clinical trial. The baseline data that is collected includes a detailed medical history, physical neurological exam, cognitive exams that include, but not limited to, ADAS cognitive subscale, MMSE. There's extensive lab work, and of course, imaging studies, including CT to estimate the skull density ratio that is required for FUS treatments, and then beta amyloid PET and structural and functional MRI. The patients then undergo 3 focused ultrasound mediated BBB treatments, each 2 weeks apart. And for each treatment, the target regions with high beta amyloid burden are carefully selected. FUS mediated BBB opening is performed. There is an immediate post-treatment MRI with contrast, and then post-treatment MRI scans at 24 and 48 hours, and if needed, 72 hours as well. And of course, there are several neurological exams at different stages. 7 days after the last treatment, the patients undergo extensive workup again, including a PET scan. And then the subsequent follow-ups are at days 30, just 3 months, 6 months, 1 month, 3 months, 6 months, and 1 year. So far, 15 participants have been enrolled, 8 at WVU, 5 at Ohio State, and 2 at Cornell. These 15 patients have undergone 45 separate FUS treatments, and so far the follow-up ranges between 3 and about 33 months. To achieve the low intensity FUS BBB opening, patients have stereotactic head frames placed. There are the systems, frameless systems are being developed, and we think that we should be able to start using those in another 3 to 4 months. Anatomical targets with a high beta amyloid load are carefully selected in hippocampus, frontal, and parietal lobes. In the beginning, for the first few patients, the targets were limited to a maximum of 5 cubic centimeter volume, only in the hippocampus and entorhinal cortex. And then we subsequently expanded that to the frontal and the parietal lobes, and to larger volumes and multiple target regions, up to 30 cubic centimeters. We are using a low frequency 220 kilohertz system from Inside Tech. It's the model number is listed on the slide. and the microbubbles used are DEFINITY. In the beginning, when we were targeting small volumes, we were using boluses of microbubbles. But since we have transitioned to multiple targets and larger volumes, we now use IV infusions of the microbubbles. So far, out of the 15 participants that have completed 45 treatments, we have achieved safe and reversible BBB opening in all of them. The BBB opening is immediate and resolves within 24 to 48 hours in most of the patients. There have been no imaging adverse events, no permanent clinical adverse events. In patients where we have targeted parietal lobes, we have seen some transient neglect, which typically resolves within 1 to 3 days. We have so far we have a 1-year cognitive follow-up in 8 participants, and we have baseline and 60-day PET images in 10 participants. The quantification of a BBB opening is achieved by manual segmentation of the enhanced region based on T1 weighted gadolinium enhanced MRI. These images are then reviewed by 3 independent experts, which include neuroradiologists and neurosurgeons. And then the targeted FUS volumes are compared with so the targets are compared with the contrast enhancements in those targeted regions. And here you see some of our early results. In the hippocampus, we have so far seen an average of 95% of BBB opening in the focused ultrasound treatment or target zones. In the frontal and parietal lobes, we have seen an average of about 75% of BBB opening in the first treatment zones. And as I mentioned earlier, up to 30 cc of brain volume has been targeted. Now, not all patients have had this much brain volume targeted, but I believe 7 or 8 out of these 15 patients have had this much volume targeted. Now, in the figure on the right, you see this is the MRI evidence of the BBB opening and closure. A is the left hippocampus in one of our patients. B is the right frontal lobe, and C is the right parietal lobe. Images marked as 1 are axial T2 weighted MRI images that show the treatment target sites. Images marked as 2 are the baseline axial T1 MRI, T1 weighted images with contrast prior to the first treatments. 3 are the axial T1 MRI weighted images showing immediate BBB opening as demonstrated by the presence of parenchymal contrast enhancement at the target sites. You can see the arrowheads showing that. And then lastly, 4 are the axial T1 with contrast images that demonstrate the absence of parenchymal contrast enhancement that indicates resolution of the BBB opening at 24 hours. Here are the results of the cognitive outcome. Now, 8 participants have completed 1-year follow-up. And this is at 1-year follow-up for MMSE and ADAS-Cog. The table shows a comparison to an age and sex-matched ADNI cohort. For those of you who are not familiar with ADNI, the Alzheimer's disease ADNI is the Alzheimer's disease neuroimaging initiative, which is a longitudinal multi-center study designed to develop clinical imaging and biochemical markers for the detection and tracking of Alzheimer's disease. This data is publicly available. And as you can see, when you compare the 1-year follow-up results with the baseline for the study cohort, the relative change at 1 year in MMSE was 2.2 as compared to 3.8 for the age and sex matched ADNI cohort. And the relative change in ADAS cognitive subscale was 4.6 for the study cohort as compared to 5.6 for the ADNI cohort. Now, although these numbers show a trend for less cognitive decline, of course, this is a limited sample and no clinical claims can be made. But however, we can say that there's no meaningful cognitive or behavioral worsening in the study cohort as compared to the ADNI group. The PET images were obtained at baseline and then after the treatments, which is around 60-day time point. And over here, so you can see that the PET processing, the images are processed and the computation of SUV, the standard uptake values, is done at baseline and then at 60-day time point. The targets on the MRI are then segmented and regions of interest based on the anatomical targets are defined. Then the SUV ratios for each region of interest is calculated. And then this is standardized to a centiloid scale. Now, the amyloid imaging with PET has produced remarkably consistent qualitative findings across a large number of studies and centers. However, there's been a considerable variability in the exact numbers or the quantitative outcomes when it comes to tracer retention. So a common quantitative output value for beta amyloid imaging across tracers and methods can certainly allow for better comparison of data across sites, which can obviously help with the application of universal diagnostic and prognostic values. And this is what has driven the creation of a 100-point scale called the centiloid, which is an average value of 0 in high certainty amyloid negative subjects and an average volume of 100, value of 100 in typical Alzheimer's disease patients. Calibration to a centiloid scale then allows the results to be compared across sites. Now, as I mentioned, that we have PET results for 10 participants. And here you see those on the centiloid scale. And so far, we have seen an average beta amyloid reduction of about 26% on the centiloid scale in the treated regions after the treatments. As you can see, the subject ID 4 does not show any change. This is one patient where only hippocampus and internal cortex was treated, who had a low amyloid burden to begin with, and that patient did not show any change. Of course, this is a small sample size, and the interpretation is limited. the patients in the study had various degree of beta amyloid burden, some with low, particularly the ones where we only targeted the hippocampus and the intralinear cortex. The potential mechanisms for FUS BBB opening and the amyloid clearance is of course, remains under investigation. One hypothesis is that FUS mediated BBB opening results in focused local inflammation, which is immunologically driven, leads to neutrophil and microglial recruitment. Another hypothesis is that there is perhaps enhanced removal and clearance of substrates mediated via lymphatics. But of course, more work needs to be done to better understand that. So in summary, so far in this trial, we have achieved safe BBB opening in all 15 subjects in the hippocampus, internal cortex, frontal and parietal lobes across 45 distinct treatment sessions. This BBB opening was on demand, it was transient, reversible, and completely resolved, mostly in 24 to 48 hours. And the BBB opening was achieved in 75% of the target treatment zone, or at least 75% of the target treatment zone. These, as all the sonications were well tolerated across multiple superficial and deep brain structures, PL surfaces, ventricles, up to 30 cc's in volume. There were no overt hemorrhages or adverse events. There was no deterioration in neurological or cognitive function. For the cognitive function, even compared to an age and sex matched ADNI cohort. And that there was a reduction in beta amyloid plaques in the 10 subjects that we have the data for. Of course, this is an ongoing study, and we need more data and a long-term follow-up to draw any meaningful conclusions. And there's several limitations of the data that I've presented today. This is a small sample size. Longer follow-up is needed. Of course, sham control studies are needed. And there's a heterogeneity of the target volume, the target location, the tissue characteristics, and the beta amyloid distribution. It's an ongoing study. So far, 4 centers are involved, a big team. The centers include the Rockefeller Neuroscience Institute at the WVU, Cornell, Sheba University in Israel, and Ohio State University. And there are more centers that are coming online in near future. I thank all of you for your attention. And once again, I'm really thankful to be able to present this data to you today. Due to the nature of my presentation being this a virtual presentation with a significant time difference, I'm not able to answer any questions, but my email, you can see my email address up on the slide, and I'd be happy to answer any questions via email. Thank you all.